Thanks, Jared. Great. Well, thanks for that introduction. As Jared said, I'm Don Mitckess. I'm Director of Clinical Outreach for Banyan Treatment Centers. I've been with Banyan about a little over 5 years. And prior to being at Banyan, I was at Alexian Brothers Behavioral Health Hospital, and I had the privilege of doing clinical outreach for the self-injury programs and the eating disorder programs there. So we were fortunate that we had some of the foremost thought leaders in this topic working there at the time that I got to learn a lot from. So and I'm here to share it with you today. So let me can I tell you that Zoom is a lot of fun, so I'm going to figure out how to share this with you. All right, so there we go. Okay. That is not where I want to start. That is the end. Let's go to the beginning. Okay. Apologize, folks. My technology is being. There we go. All right, so let's try that again. Can everyone see this?
We're good.
Excellent, excellent. Okay. So this is a topic that at Alexian we did a lot of community education on, but there still is a lot of misinformation about there or misunderstandings about self-injury as a behavior. So hopefully today we can cover some of what makes self-injury something that can be addressed effectively, and recognizing what is driving the behavior, because that's really a key thing about self-injury. And really, place to start is, what is it? So there's a lot of definitions out there, a lot of thoughts about self-injury, but the International Society for the Study of Self-Injury came up with this definition. First and foremost, it's a behavior. And it's the deliberate self-inflicted destruction of body tissue without suicidal intent and for purposes not socially sanctioned. And that second part is important because there are behaviors that people engage in that could be thought of in different cultural contexts as self-injury in a different context, but in their particular culture or in that particular socially sanctioned behavior, it's a socially sanctioned behavior. So it's not necessarily considered self-injury. So oftentimes, and I did a lot of work in emergency rooms over the years, that someone coming in with a self-inflicted injury, the automatic thought for the medical professionals is they're trying to kill themselves. They're suicidal. They're trying to end their lives. And non-suicidal self-injury and suicide are not generally the same. There is suicidal self-injury, which is injuring with the purpose or intent of killing themselves. That's in a suicide attempt, for instance. Non-suicidal self-injury involves an act of self-injury for purposes other than killing oneself. And those, it's often called cutting, but there are many different ways that people injure. Cutting is just one form of self-injury. A common form of injury with folks that we work with on the substance use side of things is actually violence against objects, punching walls, banging their head, getting into fights that they wouldn't necessarily be able to win or come out on the good side of. Can also be a form of self-injury. Over the years, there's been a ton of different ways that people have described this behavior, everything from parasuicide to suicide related to self-destructive to self-abuse. But the agreed upon term for this behavior by those that have studied it is non-suicidal self-injury. Things to take into consideration are, especially if you're in a setting where a residential setting, sober living setting, hospital setting is that pretty much anything that has some sort of edge or abrasive feature to it can be used as a tool to self-injure. So if you come in and you recognize that someone has a history with this type of behavior, it's really important that you are aware of what is in their environment, what is available to them. Now, if someone's really highly motivated to self-injure, and there are those that are, they will find a way. They will find a way. But everything from fingernails to teeth have been used to self-injure. So, but it's important that there's a bit of a, for a lot of folks, there's a bit of a ritualistic aspect to self-injury. So it's, if they have preferred tools, it's important that those preferred tools are not made available to them in their environment. So why do people do this? Right? When I started in this field, and before I worked at Alexian Brothers or at Linden Oaks Hospital, and having dealt specifically with folks with this particular issue, the idea of someone self-injuring seemed a little crazy, right? I mean, why would someone do that? It doesn't make sense. Why would you hurt yourself? And the thing is that behavior of self-injuring serves a function, and it's typically one of two things. Sometimes it's both, but typically it's one of two things. They're either trying to change their own internal experience, their internal emotional experience, or they're trying to change their relationship with other people. So either intrapersonal or interpersonal. But this behavior serves a purpose to that individual. I can't express this enough. This is getting to what the purpose of this behavior is for that individual is key in being able to address it. It's key in being able to recognize what triggers it. Because just like substance use, self-injury can be a triggered behavior. So getting to what drives the behavior is important in being able to address it. So the typical self-specific reasons why people self-injure have been kind of categorized in 13 different categories, and they're listed here. And everything from autonomy to toughness, and we're going to talk a little bit about what each of those means. But if you can get to what their particular motivation amongst these 13 potential reasons are, will help you in addressing what can trigger it or what's driving the behavior, and then you can have discussions about it, or you can clue in, if you're not a clinician, clue in their treatment team as far as, well, this seems to be why they're engaging in this behavior, or this seems to be triggering this behavior. So there's a researcher in ISSS, International Society of Self-Injury, came up with an inventory statements about self-injury, and that will help determine which category these folks fall under. So when I harm myself, I am, for someone who is seeking affect regulation, I am trying to calm myself down. So heightened emotional states, folks who self-injure, this becomes their primary, and pardon the term, but it is, self-injury becomes the tool for them to regulate their emotions. They experience a heightened emotional state. It triggers an urge to self-injure. They self-injure, and it helps them calm down. It helps them regulate themselves. Another reason is self-punishment. I self-injure because I'm expressing anger towards myself for being worthless or stupid. So this is a way that for those that are, particularly those that have experienced trauma, this is a way that they can, when they experience anger, in regards to their self-worth, it'll trigger to self-injure. Anti-suicide. It seems idiosyncratic, but there are people who their trigger for self-injuring is actually to stop themselves from feeling suicidal. Rather than kill myself, I'll injure myself. Anti-disassociation. There are folks that, especially again, those that have experienced significant trauma, that feel emotionally numb, and they injure in order to feel something. Self-injury over a period of time does release things like endorphins. So they injure in order to feel something. Interpersonal influence. They injure in order to let others know the extent of their physical or emotional pain. I'm trying to send you a message. Usually it's to family, right? Sensation seeking, doing something to generate excitement or exhilaration. This is, these are folks that's not necessarily cutting as their form of self-injury, but it might be something that's physically risky or often involves getting injured during the course of that behavior. Peer bonding. Wow, we see a lot of this. One of the more remarkable things about self-injury as a behavior is that we're seeing it in younger and younger cohorts, right? We're seeing it in kids that that use it as a social identifier. In middle school, you find your people, right? You find people who are doing similar things, have similar interests, and use that as a means to bond and form friendships. For some people, it's sports. For some people, it's movies. For some people, it's self-injury. It becomes a social identifier that a group of people can cluster around. Typically, we've seen this a lot in middle school age kids, where those that are feeling disenfranchised find this group, and usually there's one or two that are more seriously self-injuring, and cause something of a contagion effect within that group. Self-care. Creating physical injury to take care of. This physical injury is easier for me to take care of than the emotional distress that I'm experiencing. Marking distress, creating a physical sign that they feel distressed, that they are feeling emotionally down, depressed, and it's a way to mark it for themselves. It's not necessarily for interpersonal influence, but they are marking it on their bodies, the sign of their internal distress. Interpersonal boundaries, creating boundary between myself and others. Self-injury is a behavior that often causes repulsion in others, right? So if your goal is to be alone, self-injury is a way that you can push others away. Who wants to hang around with that kid, right? Toughness, seeing if I can stand the pain. Revenge, getting back at someone. Or autonomy, demonstrating I do not need to rely on others for help. What we have found is that the first two, affect regulation and self-punishment, make up a majority of the reasons that people self-injure. Approximately 70% of folks that self-injure are doing it for affect regulation. About 40% report that they use self-injury as a form of self-punishment. Now, here's the other thing. It's not often one category, one motivation for the behavior. Oftentimes there's crossover. There could be two or sometimes three. But it's getting to what is this doing for you, right? How do you approach these folks? We'll talk a little bit about that. So again, this gets a little bit more specific into, and I will, I'm going to send this PowerPoint to Jarrett to share with the folks that are here today. So, and I know you guys can read. So rather than going over this, we kind of talked a little bit about each of these, the affect regulation and self-punishment. Again, these tend to be the top two reasons that people self-injure. And again, this goes over some of the others: marking distress, anti-suicide, self-care, interpersonal influence, and boundaries. And again, two main functions. And starting out with which of these two main functions that it serves for them can help kind of guide your investigation into what's driving this behavior, whether it's an internal function for a social function, or interpersonal versus interpersonal. As I mentioned, there are several different methods for self-injury. Everything, again, from cutting is one, picking, scratching. The thing about picking is you need to determine whether or not it's picking because of one of the reasons, affective regulation or something like that, whether it's something related to trichotillomania, which is an anxiety disorder, right? Biting, fighting, burning. We had kids that would take a black Sharpie and make a very dark square on their skin, and then take their cell phones and use the flash function over and over on that black square, which intensified light would cause a burn. There was a period of time there was a rash of embedding. And embedding is taking an object and embedding it under the skin, a pin, tack, something that they can embed under the skin, and then they could rub that area and get the same sensation as if they were cutting. Excessive piercings, that's something to explore. Piercing is a socially sanctioned behavior for folks in the United States, right? So is it a method of self-expression, or are they marking some emotional distress or pain by a new piercing? So again, it's asking the questions of what does that do for you? And if it's, hey, this is just how I express myself, that's okay, right? It's okay for that sort of self-expression. It's socially sanctioned. Excessive tattoos, right? Full sleeve tattoos. Is this something that you're doing to, express or memorialize somebody or an event? Great. Are you doing it because, it's something that's marking a trauma for you, right? So that's where the digging in and diving in and asking those questions becomes important. What's motivating? What's driving the behavior? So some methods of self-injury by percentage, typically by far cutting is the most common. Scraping, scratching is next. Banging. Now, what we found is that we've seen self-injuring behavior in children as young as 7, 8, 6 years old, right? When they're that young, their form of self-injury tends to be more banging head, punching walls. When you get into middle school and high school, 9th grade and above, it tends to be more along the lines of cutting or burning. How severe is the injury typically that we see? Here's the thing about is that most of it we tend to see is mild. There's a very small percentage of people that severely self-injure, and those are the ones that really need a higher level of care. We'll talk about what severe self-injury looks like as far as how to quantify that. For those that, because they may be injured, their intention may not be to end their life, but they may self-injure so severely or so frequently that they're putting their life at risk or their health at risk. This is a behavior that is comorbid with a lot of conditions, right? You can see here by the research that's been done, depression tends to be highly correlated with self-injury, impulse control disorder, drug use disorder, right? About 1 in 5, 1 in 4, 1 in 5 people who have some substance use disorder are also self-injuring. So how common is it? So for adolescents, what we see as far as single episodes, the numbers vary pretty widely, but it's somewhere in the area of 17 to 35%. So that means is anytime you see a kid, there's a pretty good chance that they have engaged in this behavior at some point, a single episode. That's the thing about adolescence as a stage of development is that adolescents are trying on different behaviors to see what does it for them, right? We see this with substance use. How do I feel good, right? Chemically, I can take chemical shortcuts to feel good, right? I can drink, I can smoke pot, I can experiment with other drugs. And or self-injury is another method of this person does it and it makes them feel better. Let's try it, right? See it on TikTok, see it on Instagram, you see it. I mean, social media is a great vector for contagion for this sort of behavior, right? So most kids that try this behavior won't do it again because it doesn't do anything for them. They try it out, it sucks, and they don't do it again. Now, for those that try it out and get something out of it, that's a little bit less. That's a little less than 7% of kids will have repeated episodes, meaning 5 or more. They've passed the experimental stage, much like we see an experimental stage for substance use, right? They figured out that it's going to do something for them, that it fills some sort of need that they have, and they're going to keep doing it. So roughly speaking, 1 out of 14, 15 kids that you see, adolescents you're going to see, are engaging in repeated self-injuring behavior. Now, for adults, adults don't typically engage in this behavior once they reach the adult stage, but there's a small percentage that do, right? 6%, though, and about 3% will move on to a more repeated pattern of it, right? The Klonsky and Mitckess are 2 leading researchers in this area. Their research shows the age of onset as 12 to 15. What we saw at Alexian Brothers because we had a PHP program for self-injury and an inpatient unit for self-injury, we found that for those that needed that level of care, that level of intensity, PHP or inpatient, their age of onset typically was 8 or 9. So we're starting at a much younger age. Again, much like we see with folks that are engaged that have a substance use disorder, right? The earlier the onset of the behavior, the more likelihood that they're going to develop a serious issue with it. So what are the risks for someone developing a pattern of self-injurious behavior? Trauma, right? Those that have developed poor distress tolerance or coping skills, high emotional reactivity, those that tend to be ruminative, folks with things like obsessive compulsive disorder, people who can have proclivity towards self-injuring behavior, those that have developed a dissociative disorder, those that have been abused, parenting conflict, parenting lack of support. Do all of these things look familiar to you guys? Right? So the very similar risk factors for substance use disorder are very similar risk factors for those to develop a pattern of self-injury. Again, which is why there's such a high correlation between the 2 behaviors, right? Also the thing to watch out for is what I'd like to refer as clinical whack-a-mole, right? You may be working with someone who's in early sobriety, right? Struggling to stay sober, work in a program, but they still haven't gotten to the point where they've developed adaptive coping skills, and old behaviors will resurface, right? Old adaptive behaviors. So rather than getting high, they may resort back to an old self-injuring behavior, which is why in your assessment of folks, it's important to explore, has this been a pattern of behavior before, right? Because then it makes you mindful that this is something you need to look out for and ask about as they're going through their recovery process. Are you having any urges? Are you feeling triggered to engage in these old behaviors, right? Have those discussions. So gosh, can I just, I don't know how many times I've had a parent say, you know what, they're just doing it for attention. You know what my answer to that is? Yes, they're doing it for attention. They're doing it for your attention, very likely. If they're doing it and doing it in a way that is obvious to all of them around you, if they do it because they know it triggers your anger or disgust, are they doing it for attention? Yes. So you need to pay attention, right? You need to give them attention they need so they don't have to engage in this behavior. It's not borderline personality disorder. There's an old version of DSM that said self-injury was a criteria for BPD. There's a high correlation. There's about a 50% correlation. Those that suffer from borderline personality disorder, there's a fairly high likelihood that they have or do engage in self-injuring behavior, right? It's a way to draw people in. It's a way to push people away, which is a great, which is endemic for those that suffer from BPD, right? It's their problem is relational, right? So there folks that suffer from BPD are going to engage in behaviors that are going to attract attention in a very negative way. And again, it's not a suicide attempt necessarily. Can it be dangerous? Yes. Can it be physically hurtful? Yes. Don't automatically jump to someone who self-injures is trying to end their life. You got to ask them the question, right? All right. So asking about how do you engage in this conversation, right? How do you do that? It's easy to say, hey, how often are you drinking, right? How much do you drink? Oh, one drink. How big is that drink? Is it this big? Is it this big? Right? Asking about this behavior is a little bit more, I'll use a clinical term, a little bit more oogie, right? Focus on the behavior, not the person. We have to take judgment out of it. Just like we take judgment out of the fact that we're dealing with folks that are, that their primary issue is substance use. To judge them is to invoke guilt and shame. And when we invoke guilt and shame, it becomes a barrier, right? It triggers them, it takes them farther away from getting help. So, simple way to ask it, I noticed that you have some wounds and scars, right? Can you tell me where they came from? Or it looks like you're hurting yourself. Can you tell me how you hurt yourself? How often do you do it? How often do you engage in this behavior? And are there other places that I can't see that they have wounds or scars? Don't ask to see them if they're hidden. Don't do that. Keep the wounds in the realm of wound care, right? So if someone has a wound that's obviously not tended, right? Let's get you to the nurse. Let's get you to the school nurse. Let's get you to the urgent care center. Let's have our doc take a look at that. Okay. Treat the wounds as what they are, which is a medical issue. You have to address them medically. You have to, because wounds that are untended or complicated need to be attended to, right? Because they can become complicated, infected, et cetera, et cetera. So don't resist the urge to go, wow, that's really bad. Don't attach judgment to the wounds, right? When you attach judgment to the wounds, again, engenders guilt, shame, and makes it about them. And please, and this is one point I'm going to get up on a soapbox, please don't refer people who engage in this behavior as cutters. The people are not their behavior. It's a behavior they engage in. And all too frequently, I've worked with outpatient counselors, therapists, ER staff, doctors who insist on calling them cutters, right? And as opposed to folks who are in the substance use part of the field where you identify as an alcoholic, identify as an addict, that creates empowerment, right? This is who I am and what I am dealing with, right? And I have to have that recognition in order to maintain my sobriety, in order to move forward in my recovery. For those that engage in self-injury, when they are identify themselves as a cutter, it's a trigger long-term. So you have to separate the person from the behavior. They're not cutters, they are people who self-injure. They are people who engage in self-injurious behavior. It's counterproductive to label them as such, especially our adolescents. Our adolescents are at a stage where they're, developmentally speaking, they're solidifying their sense of self and their identity, right? And if they hardwire in cutter as part of their identity, it becomes harder and harder to treat farther down the line, because it becomes endemic to who they are and how they see themselves. So I encourage you, separate the person from the behavior. Interventions. If you've done any DBT training, please don't do any of the things DBT tells you to do as far as behavior, coping skills, coping alternatives, or self-injury. Don't use ice cubes. Don't use snapping rubber bands when you're triggered to self-injure. Don't use red markers to simulate a self-injury. These are skills. Don't say, go have a smoke if you're triggered to self-injure. The reasons for that is that it's just reinforcing that. It's reinforcing the steps and the ritual of those behaviors, right? Again, self-injurers, folks that self-injure tend to ritualize the act of the injury. So oftentimes they'll often have a kit or a tool that they have secreted away in a particular place at a particular time. So if you're allowing them to do things that will mimic it, like the red marker, right? Snapping a rubber band is going to trigger a similar physiological response as self-injuring, right? It doesn't cause an injury, but it's reinforcing that physiological response that people have. And ice cubes can actually cause tissue damage. So these are the things that have been promoted previously to provide coping alternatives for those that self-injure, but they're not effective, and try to avoid those. And if someone is actively injuring, discourage them from any new piercings or tattoos, right? When they're farther along in their recovery and they want to re-engage in those acts, God bless. But while they're in their active stage of treatment for self-injury, or they're actively injuring, it's something that should be avoided. Okay. Oh, there we go. Avoid. So controlling. We've talked about these things. So it's to talk about the functional model. We've already talked about these other things, but really talk about what the function of the behavior is, right? The behavior is being driven by something. So that's what the discussion should be about, whether it's with family, whether it's with the individual, this is doing something for you, right? You're getting something out of this. So what is it? Let's get to it, right? Let's see if there's some other way you can fill that need without engaging in this behavior. So interventions, what can you do, right? The urge to self-injure is often very similar to the urge to drink or to use, right? It's being triggered. So sometimes those triggers are cognitive distortions. So I think I'm a piece of crap. And if I think I'm a piece of crap, I deserve to hurt myself, right? So challenging that cognitive distortion that person has worth, has value. Distress tolerance. That's one of the great things about DBT, is it teaches distress tolerance. Distress tolerance, if you can teach them how to sit with that trigger, that feeling, that urge to self-injure, through, utilizing deep breathing exercises, relaxation exercises, positive imagery, going to a journal, right? And get them through that, that 5 to 10 minute urge to engage in the behavior will help lessen that trigger for them, right? And it's very important that in the course of intervening with an individual that's self-injuring is intervening with their support system. You got to teach the family too, significant others, their support, the people who are there that are saying, I'm here to support them. They need to know all of these things too, right? Because if they don't, their reaction to their negative reaction to a self-injurious behavior or incident or an episode can very well trigger a continuation of the behavior. So when we say treated, this is looking at a treatment at a higher level of care. Someone who is injuring repeatedly, frequently, that this is become one of their main coping skills. Chances are they're going to need to be treated at a higher level of care than an outpatient therapist, right? So repeated self-injury, serious self-injury. Again, most self-injurious behavior is filling a need, right? But when someone self-injures the injury is more serious than they intended, right? Cuts that require stitches that reach the fat or muscle layer, large bruises, burning that results in second degree or worse burns, right? Embedding it at all, or swallowing objects, or injuring in areas that can cause some permanent serious harm. So face, neck, genital areas, right? Which we see a lot with folks that experience serious trauma. Those sorts of self-injuring behaviors need to be treated at a higher level of care. So it's I can tell you some stories, and I'll forego it because they're sensational, but the lengths that people go to self-injure that are engaged in more serious behavior can be pretty extreme. Or self-injuries that's resulted in a more severe injury than expected. Like they cut themselves and they're used to cutting themselves in a particular way, but this one, boy, they went deeper. Wow, okay. Well, boy, I did that more. I dissociated, and boy, I injured myself more than I had intended, right? Those folks need treatment at a higher level of care. Again, we're looking potentially inpatient, potentially a day program, but someplace that knows their way around self-injury. And not every program does, just so you know. Any suicidal thoughts or behaviors, again, safety first, right? So if someone is suicidal, and someone who engages in self-injuring behavior is 4 times more likely to experience suicidal thoughts or ideations than the general population. Or if they have a co-occurring condition that is complicated by their self-injury. So again, we're looking at substance use, eating disorders, serious psychotic type conditions, schizoaffective, schizophrenia. They're experiencing command hallucinations. Again, those need to be treated at a higher level of care. So again, repeated self-injury 5 or more times in the past year, serious self-injury, suicidal thoughts or behaviors, if no other disorders are present. If they injure specifically when they're drunk or high, all right, that needs to be addressed at a higher level of care, or strong repeated urges to self-injure that they cannot control or manage. This is, and again, we'll send this out. This is a level of care criteria. It's similar to the level of care criteria that you see from the APA for different types of conditions. The APA didn't have level of care criteria for self-injury as a behavior. So we folks at Election Brothers came up with one, and here it is. So you can take a look at it if you're having a question about what level of care might be appropriate. this is a grid that can help you make that determination on assessment. Okay, if they need to be seen immediately, or if they could be managed in outpatient, etc. All right. Again, general treatment goals: increase motivation to use alternatives, improve healthy emotional regulation, develop and maintain a healthy and functional sense of self, decrease suicidal thoughts, and increase their number of healthy social supports and family functioning. Right. Again, these are all general treatment goals that we have for people who are using substances, right? So, so a lot of these things can be cross-pollinated into the addressing of self-injurious behavior. ERGT is the one treatment modality that has been researched at an IOP level of care, right? There's not a lot of research about self-injury. There's the International Society for the Study of Non-Suicidal Self-Injury, who has all the thought leaders about this across the globe, has about 70 members. It's a very small community, very small amount of people that are doing research on this. So ERGT, if you want to take a look at it, CRADC is the main researcher. It's a model to treat this particular condition that's been found effective through research. So this is the book that we put out at Alexian Brothers back in 2014. It's available on Amazon or as a Kindle download. We found that because there was such misunderstanding and misinformation about self-injury and not a lot of good guidance. A lot of the stuff that was being published by academics and wasn't particularly useful for people on the ground level, right? So counselors, therapists, nurses, ER staff, people in treatment programs that don't necessarily treat this specifically, we wrote this book. We thought, hey, we'll get a whole group of us together. We got 10 people together to write this book. We're like, we'll knock this out in 6 months. Took us 3 years, but we got there. And it's just a handy, quick reference guide for different aspects of how to address self-injury, everything from the things that we talked about the different typologies to how do you talk to a family about this? A lot of, how do you intervene? How do you have the discussion? It's based in a question and answer format. So if you have a question about this behavior or how to deal with something in regards to it, it's all in that book. So with that question, we're about 10 minutes out. So
yeah, Don, thank you so much. That was phenomenal. I'm going to open it up for questions. If you have a question or comment, you can raise your tiny digital hand on Zoom and we'll get to you. I just want to start off with one while we get some others lined up, which is, I can assume that, as somebody who's in long-term recovery from substance use, I know the stigmas that are attached to that, and I can only assume the stigmas that are attached to self-injury can be sometimes even greater. Like, in your opinion, what are some ways that, even those of us who might not have this affliction kind of work to dispel some of the stigma that's attached to it?
And that's what we're fighting against with the stigma is the natural revulsion to someone hurting themselves, right? In some ways more so than alcohol or drug use. We see similar stigma with eating disorders. Why don't you go eat a sandwich, right? So it's education. It's talking about it, right? Saying this is a behavior. This is not who this person is. It's what they do. And they're trying to cope. They're trying to deal. You may deal by knocking back a pint of vodka. That's how you're dealing, and not very well, but right, they're suffering in the same way. This behavior is helping them in some way. It's helping them deal with whatever emotional pain they're experiencing internally. It's not the healthy way to do it, but it's what they're doing, right? So we have to have some grace and sympathy for those folks and understanding. So and you have to, just like any other stigma, you have to confront it as it happens, right? you have to engage in teachable moments with folks that are, by no fault of their own. This is, it's a natural reaction to go, holy crap, you just cut yourself. What the hell are you doing? Right. So it's at those moments that you have to, be willing and brave enough to confront and educate.
Absolutely. There are a couple questions in the chat. If you want to ask a question, you can feel free to put up your hand or unmute. But I know the first one Gina asked was about the difference between interpersonal influence and marking distress.
So the interpersonal influence is more about is more interpersonal. Marking distress is more intrapersonal. Right, they're marking the distress for themselves. With intrapersonal influence, they're trying to influence someone in their environment with the behavior.
If anybody else has a question or comment, you can feel free to unmute. Danny, you want to go ahead?
Sure. Hey, Don, first I wanted to say thanks again for doing this presentation for us. It was great. Sorry I was a few minutes late today. But I wanted to point out a couple of things that you said that I think are important. One, that is not just for attention, and to figure out what is it that the person who is engaging in the non-suicidal self-injury, what do they need? That's so important. And another part that, when you added how risky behavior is is a part of not self-injury, right? You're like, oh, I'm just doing that, I'm not hurting myself, I'm not cutting, I'm not burning, I'm not doing what other people would see as self-injury. But if you're engaging in risky behavior that, could put you at risk for an STD, to put you at risk of an accident, whatever it might be, all those are also self-injurious behavior. So I'm really glad that you pointed that out. Thank you.
Please, Danny.
Kat, did you want to jump on?
Yeah, so this was a really interesting presentation for me to attend, because I did a presentation actually on addressing non-suicidal self-injury stigma. And a lot of what was in here was very relevant. And I found a couple of different research articles that more specifically address how to address stigma, and looking at like the different kinds of stigma that can result from non-suicidal self-injury. And one of the ones that I wasn't even really aware of as a person with lived experience of this is self-stigma. So really diving into like talking about those risk factors for developing non-suicidal self-injury. The Cornell program on research program on non-suicidal self-injury in 2019 kind of did a deep dive into what is the effect on the neurobiology. And it really outlines like there is a higher likelihood of individuals to develop a very self-critical viewpoint of themselves.
Absolutely. There's a good chapter in the self-injury book on medical aspects of it. It's I didn't want to do too deep of a dive on neurobiology, just because it's not necessarily, but there's some great stuff going on at Cornell. There's some great stuff going on in Australia. I'll tell you, Australia is fantastic from the governmental perspective on how much they financially support research in a lot of different areas, but in particular self-injury.
Excellent. Thanks, Kat, and thanks for being here, Kat. We appreciate it. Anybody else have a question or comment with the time we got left? Going once, going twice.
Feel free to reach out to me if you have any questions. My number's there. Like I said, I'll send this out to Jared and Danny to push out to the group. And yeah, feel free to use it. Feel free to reach out with any questions or concerns or comments.
Yeah, Don, thank you again for presenting for us. That was like I said at the beginning, it was a very helpful personally for the blind spot that I had to that particular part of a mental health struggle. So yeah, I will definitely be sending this out to everybody, and I'll be putting up the recording on YouTube later today so we can share that too for anybody that wasn't able to be here. So Don, thanks again, and everyone else, thank you for being here, and we'll hopefully see you at the holiday party in December. Everybody have a wonderful day.
Thanks, everyone.